Good evening, everyone. First of all, let me start by thanking Professor Andrew Bolter, who agreed to be speaker of this very important program, which Diabetes India is doing. I am Dr. Bansi Sabu, currently Secretary for Diabetes India. We have with us Dr. Andrew Bolton and Professor Shashank Joshi. I'll be introducing them. Let me share my slide before I start. Today we have agenda that I'll be talking, and then later on Dr. Andrew Bolton for 30 minutes he'll be talking for diabetic peripheral neuropathy, an overview of disease pathogenesis, treatment objective, and what latest guidelines. We all know he is the person of diabetic foot, diabetic neuropathy. He's a past president of International Diabetic Federation. He's a past president of European Association of Study of Diabetes. After him, Dr. Shashank Joshi, Padma Shri from Mumbai. He's a senior consultant endocrinologist from Lilavati Hospital. He's a past president of our RSSDI, Endocrine Society of India, and Association Physician of India. He's also past chair of International Diabetic Federation of Southeast Asia region. He's also very active member of our Diabetes India, chief advisor, and last year he was scientific chair. With this, what I'm going to talk in next 2-3 minutes, that what is the challenges, what are the management issue, but it will be later on covered by Dr. Andrew Bolton, and then finally management will be done by Dr. Shashank Joshi. This is what the diabetic neuropathy. We have 101 million people with type 2 diabetes patient. And diabetic peripheral neuropathy, probably 50% of them have diabetic peripheral. The challenge is the diabetic peripheral neuropathy, even with a pre-diabetic population, is also very high. It may be ranging between 6 to 25%. So you can understand the number of people who have diabetic peripheral neuropathy is very, very high. We have highest number of type 2 diabetic patients in our country, second highest after China, and same way pre-diabetic population is also very high. Diabetic neuropathy is actually gives very impaired quality of life. People with diabetic peripheral neuropathy have very low quality of life. Their mental and physical well-being is very low. They have pain very severe, and sometimes that leads to their sleep issue, as many emotional issues are also there. They may go for anxiety, depression, fear, and many of the times they keep on changing the doctors because the pain is there, and they go from one physician to other physician also. Mostly there are many treatment options which are there. In India, we have in monotherapy, we have in combinations available also. Gabapentin is commonly we use, SNRIs, and tricyclic antidepressant, which is very commonly used, but it's a having toxicity too. We have topical agents, we have opioid-like drugs which are available to us, and we will discuss all these along with once Dr. Andrew Bolton will talk, and then later on what the new or what is available in India, Dr. Shashank will talk, and what are the latest therapy which is going to be introduced by Torrent Pharmaceutical, one of the largest pharmaceutical company in India, and later on we will have some discussion. So in next 60 minutes we'll be discussing, and with this now I request Professor Andrew Bolton to share his slide. He is very, very eminent figure in the field of diabetes neuropathy. He'll be talking about the pathogenesis and the guidelines. Over to Dr. Andrew Bolton. Thank you, sir.
Thank you. My slides worked before, now I can't find them. Can you see those?
No, sir. You have to share.
That's why I wanted to get them ready before. Am I sharing?
Yes, now it is showing. You are sharing your computer. Now you have to show your slides.
I shouldn't have shared them before because I had it all right before. Can you see that?
Yes, we can see your computer, not your slide.
Tika, you got the slide now?
No. So I think you have to share.
Right. It worked perfectly when I did it before. I can see that now, but you can't. But I need some help here because I'm clueless.
But you minimized your slide, so it must be there on your laptop or desktop.
Sir, I will help you out, sir.
Yes.
Sir, just go to that green button which says share.
I'll try again. Ah,
Yes,
there
sir.
we are.
I have just
Right.
removed. Yes,
That was the problem. I couldn't get it.
so that green button which shows share, and then click
There we
on.
go.
No, yes, it is done. So
Yes,
yes,
now
perfect.
you can make it full
Put
screen.
it on
Okay.
slideshow.
You can
Yes,
see it
we
now.
can see your slide. Yes, perfect.
Ah,
Done.
good.
Thank you.
Well, thank you very much. Apologies, dear friends, for that. It's a pleasure always to be speaking to friends and colleagues in India, the country that I first visited 40 years ago. And interestingly, now I'm supposedly on vacation in the home country of my wife, Professor Loretta Vilikite, who comes from Lithuania. And Lithuania has a very historic language, which is Indo-European, based upon Sanskrit. I'm not sure how many of you knew that. I've tried with Shashank to see how many words he recognizes, but I don't think there's too many, but it is an Indo-European language where I am now. So I can say to you in Lithuanian, Labas vakaras, pones pone, which is good evening, ladies and gentlemen. So I'm going to talk to you about the diabetic neuropathy, as I say here, a complication with many consequences. And this is an old classification. I've been in this game a long time. And this was 39 years ago. I wrote a review with my mentor, John Ward, looking at the diabetic neuropathy as a clinical classification, and we still use a clinical classification today. And what we're talking about this evening, what I'll be talking about, is the management mainly of chronic sensory motor neuropathy of the small fiber variety that leads to painful symptoms. I'm also going to say at the end, just a few minutes on autonomic neuropathy, some work we did many years ago that may not be familiar with you on some rare autonomic neuropathies that we found a treatment for. So diabetic symmetrical polyneuropathy is very common. Up to 50% of patients will have this. It's a symmetrical length dependent. It's a dying back neuropathy, and therefore the longest nerves are most affected. And those to the lower limbs especially are affected, and the more severe cases, the upper limbs may also be affected. It's the strongest risk factor for foot ulcers and amputations, and around half these patients will develop some form of neuropathic pain. It's associated with the other complications of diabetes. This is a paper we published many years ago in Diabetic Medicine when Aris Vevis was my research fellow. He's now a professor at Harvard. And this was a serial nerve biopsy showing this loss of nerve fiber density compared with a person with diabetes without neuropathy and someone with severe neuropathy. You can see loss of these myelinated fibers. And there are also abnormalities we demonstrated in the capillaries. So it's metabolic and microvascular as well. So here's the normal nerve here. And here's a nerve from a patient with diabetic peripheral neuropathy in this schematic diagram. So there are damage both the large myelinated fibers and the smaller unmyelinated fibers. There are occlusions to the vasa nivorum, and therefore you can have large fiber dysfunction, which leads to sensory dysfunction, especially loss of vibration perception, for example, and balance. People have lost proprioception, and motor signs and symptoms, which are not that common. And the small fibers neuropathy leads to pain, reduced sweating, and autonomic dysfunction. Now, there's no doubt that diabetic neuropathy is a common complication. Many people say it is the commonest of all the late complications of diabetes. I say late, but it can be present at diagnosis, and don't forget that, because people with type 2 diabetes have often had the disease for many years and may present with a neuropathy, painless or painful. This was a large community-based study we published about 14 years ago from the northwest of the UK, and it was community-based of more than 15,000 people with diabetes. And we used simple tests of neuropathy disability score and a neuropathy symptom score. And around a third of patients in this large population-based cohort had symptoms. 21% had significant symptoms and signs. And we also showed in this large study that neuropathy was 2 times more common in type 2 than type 1 diabetes. And of course, it's type 2 diabetes, it's a predominant variety in your country. We also showed in a subsequent study that neuropathy is a predictor of mortality. This was a 6-year follow-up of 169 diabetic patients with variable degrees of neuropathy. During this period, 18% died and 37% developed foot ulcers. Nerve conduction velocity, which is a surrogate, if you like, of a large fiber neuropathy, not only predicted ulcers, but predicted risk of mortality. So therefore, neuropathy can be a predictor of mortality in diabetes. So it should be pretty obvious by now why we need to screen all patients with diabetes for neuropathy, at least on an annual basis. Because diabetic neuropathy is symptomatic in over 50% of cases, but that means another 50% may have neuropathy and have no symptoms. We've shown in 2 studies that the annual risk of foot ulcers is 5 to 7% in those with neuropathy, that's a first ulcer, compared with less than 1% in non-neuropathic ulcers. So it's a risk factor for foot ulcers. It's especially common in older type 2 diabetic patients. As you will hear, and as you probably already know, most painful symptoms are treatable. They may not be curable, but like in medicine, we have few cures, but many treatments. And I've already said that diabetic peripheral neuropathy is a marker for generalized cardiovascular disease and mortality. So the painful neuropathy leads to very uncomfortable symptoms that are unique to each patient. So you can't say patients always present with this or that. It depends on the individual. The pain is often described as burning, shooting, stabbing, like an electrical stimulation, maybe deep aching. There are dysesthesia, maybe a sleep numbness. It's distal and it's symmetrical. If it's non-symmetrical, think of another cause. And it's worse at night, probably because there's less afferent activity in the peripheral nervous system at night. Autonomic neuropathy, also small fiber, may lead to orthostatic hypertension, cardiovascular autonomic neuropathy, the diarrhea, constipation, gastroparesis in the GI tract, incontinence, erectile dysfunction, and abnormalities of sweating. Whereas large fiber dysfunction, together with small fiber dysfunction, leads to foot ulceration, infection, and this may lead to amputation, increased risk of falls, there may be upper limb symptoms and motor symptoms. So that's the spectrum. So it is a spectrum. At one end of the spectrum, you've got people who predominantly have painful neuropathy that I've described the symptoms to you, and they also may describe, or we may find allodynia. And allodynia is when a non-noxious substance, a stimulation rather, such as touching the skin, gives rise to a painful experience. So you touch the person's toe and they say, oh, it's very painful. That is allodynia. And the symptoms are worse at night. Whereas at the other end of the spectrum, you have those with really, my feet are great, thank you very much. And when you examine them, they can't feel anything on examination. So they're at risk of foot ulceration. But most people have some symptoms and some signs. The pain of neuropathy was described very well by Dr. Favey in London in 1887 of being of a burning and unremitting character. The diagnosis is clinical. It's so important to take a history. And these days of modern medicine, I see my junior doctors who haven't even taken a history. And I say, not only do you need to listen to what the patients say to you, but hear what they say. The history of pain, they need to describe it themselves. You mustn't put words into their mouths. Distal, symmetrical, neuropathic character I've described to you, worse at night, and associated with diabetes. Symptoms are usually present with signs, but the signs may be minimal. We need to assess the severity and frequency of pains. We can use numeric rating scales, such as the graphic rating scale of a sign of 0 to 10, 10 being the worst. We can assess depression, but most of all, we need to diagnose other causes of pain. It's a clinical diagnosis. There is no test you can do, however much money you want to spend on tests. such as complex neuropathy sensory testing, multiple electrophysiology, etc. That will tell you you've got a neuropathy. It won't tell you it's due to diagnosis. So you've got to exclude other causes. As Banshee said at the beginning, neuropathic symptoms are very much associated with an impairment of quality of life. And my wife, Professor Loretta Villikite, has led the field of this, looking at how quality of life is affected by diabetic painful neuropathy. She developed the NeuroQoL scale, which is for neuropathy, and specifically in diabetic neuropathy. So there are positive and negative symptoms. Both of these have an impact on quality of life. And she's shown that the positive symptoms, pain, these patients tend to be more anxious, whereas those who've got negative symptoms but are very unstable and have falls and they can't feel their feet, these people tend to be more depressed. Painful symptoms, as I said, generate anxiety, and negative symptoms associated with depression. And of course, if you can't sleep at night because of the pain, it has a hugely negative impact on quality of life. This was a large review I did for the American Diabetes Association, like a position statement on diabetic neuropathy. And when I was a full-time professor in the University of Miami some 20 years ago, and this took months to write. It was like writing a thesis. And it's still a useful summary of all the differential diagnoses, etc. And you can download this free of charge from Diabetes Care. The year after that, late Professor Arthur Vinnick and I co-chaired the American Diabetes Association committee that looked at the position statement on the diabetic neuropathies, again published in Diabetes Care, with neurologists and diabetologists expert in the area. And basically, we said it was a diagnosis, as I've said to you, which is an exclusion of non-diabetic causes. Tight glycemic control is the only preventable therapy to prevent it. Type 1 diabetes, we should be screening all patients annually after 5 years. But type 2, as I've told you, might present with neuropathy, and therefore we screen all these people at diagnosis and annual for neuropathy. A clinical history and an examination of the essential parts. Quantitative sensory testing and electrophysiology may be useful in a few cases. For example, if the neuropathy is asymmetrical or has atypical features, or you think there might be chronic inflammatory demyelinating polyneuropathy. And there are a number of evidence-based therapies that Banshee showed a slide of for symptomatic neuropathy. So what causes neuropathic pain? I'm going to be quick on this because I really don't want to give a sort of basic lecture. This is more a clinical lecture. But neuroma properties such as ectopic impulse generation and ephaptic translation between small fibers may be important. And also blood sugar instability, glycemic flux, we call that. This is a very summary slide, and we know that you can have treatment-induced neuropathy. So if you've got someone with very bad control on oral hypoglycemic agents, and you suddenly normalize this with insulin, they can get this acute painful neuropathy. This suggests that blood glucose flux, variation might have something to do with this. We've shown that painful symptoms can improve with near normal glycemia, and hyperglycemia reduces pain thresholds. And sudden improvement, as I've said to you, in blood glucose control, even with sulfonylureas, might precipitate neuropathic pain. And we've also reported that after you suddenly normalize a patient who's got a severe neuropathy because they've got end-stage renal disease or having a pancreas kidney transplantation, obviously you suddenly normalize control as the pancreas works, and we've reported you can get acute painful neuropathy. So, could blood glucose instability excite these pain-carrying nociceptive afferent fibers or even modulate opioid receptors? And in painful neuropathy, the stability of blood glucose control may be more important than the level achieved. This is a very early study that I did when I was a research fellow with John Ward, published in 1982 in Diabetes Care. And this was a very early study of continuous subcutaneous insulin infusion, in those days using a syringe driver, no continuous glucose monitoring, we couldn't do that, with pinprick testing. And we showed in this 4-month study of patients with painful neuropathy that the neuropathic pain stabilized the more the fluctuation of blood glucose was reduced. So stable, near normal glycemic control is the first line approach, we believe. 20 years later, in the very early days of continuous glucose monitoring, we were able to look at glycemic excursions. This was in this study, we took patients with type 1 diabetes, all had peripheral neuropathy, half had symptoms and signs, very painful symptoms. The other half had the similar signs, but no pain. A painful and a painless group. They all wore the MiniMed in those days, now Medtronic, continuous glucose monitoring sensor for 3 days. And we looked at the association between pain and this blood glucose fluctuation. Some of you are too young probably to remember, this was the MiniMed, very early continuous glucose monitoring sensor here in his receiver. And we used this for 3 days in both groups of patients. This was the glucose profile of someone with painless neuropathy. And these are the subcutaneous readings from the CGM. And the squares here are the patient's own blood glucose using finger prick testing. You can see there's a very good correlation between the patient's readings and the CGM. This was a patient with painless neuropathy. I can't remember if you're in milligrams or millimoles. I think milligrams. This is 180 milligrams. That's 90. That's 360. So this control is stable in this example, but not brilliant. Now compare and contrast this, and this is a patient with painful neuropathy, much more fluctuation, poorer control, and less stability in blood glucose. And what we showed in this study, that the painful group had higher mean blood glucoses, double the number of hyperglycemic values, the geometric mean and the median were higher, and we also measured the M value and the number of glycemic excursions more than 0.5, which is 9 milligrams percent, were higher. So we showed that all these parameters were more marked in patients with painful neuropathy. And therefore, painful symptoms, patients have poorer glycemic control, higher blood glucose readings, but much more fluctuation. And this came from clinical observation, why I first started this. Because when we first started, my first diabetes clinics, we didn't have any home blood glucose monitoring. We had urinalysis. In my first clinics, in the early days of blood glucose monitoring, a couple of patients said to me, I don't need to do my blood glucose test, doctor, because I know when my blood glucose is too high or too low, because I've noticed that my neuropathic symptoms are worse. That was a patient's observation that informed the studies that I did. So always listen to the patient to hear what they say. So moving on, I was asked to chair the second diabetic neuropathy position statement by the American Diabetes Association, published in 2017. But I said, look, we need someone younger. So Veronica Popbishuri chaired this, and I co-chaired it with her. And you probably know her. She's former president of ADA, now in Portland, Oregon, but a very active researcher in diabetic neuropathy in the United States. So what I'm going to talk about now is the cost-effective diagnostic stakes to diagnose neuropathy, and talk about evidence-based recommendations for the drug management of pain. Despite having neurologists on who love all these expensive tests, we got them to agree that you don't need any of these for the clinical diagnosis of neuropathy. Simple clinical equipment, as you see here. And this is the monofilament. So the management of symptomatic diabetic neuropathy is, first of all, it's a diagnosis of exclusions. Malignant disease, a paraneoplastic syndrome. Toxins, iatrogenic, the commonest today are drugs used for malignancies, particularly the vinca alkaloids, which commonly cause a peripheral neuropathy, but they may save your life. And then we need to assess the stability and level of glycemic control, an explanation of support. We can do something to help this. You know, it can be treated, and you will get better. That's very important. And then aim for stable, optimal glycemic control, avoiding swings of glycemia, aiming for near normal glycemia, gradually get there, You don't always need insulin. That's a myth. And symptomatic improvement may be delayed. It may take a few weeks. Having said that, most people will need some medicinal therapy. In terms of pathogenetic treatments, there are basically hardly any. There is some evidence for intravenous alpha-lipoic acid or thyroidic acid antioxidant in type 2 and type 1 diabetes. So what do we have? Very, very poor evidence to suggest that non-steroidal drugs occasionally help. And yet, just 10 years ago, the ADA did a telephone survey of what drugs people were taking for painful neuropathy, and they were taking either non-steroidal drugs or opioids, both of which really shouldn't be used, especially opioids. Tricyclic drugs have until recently been first-line drugs, but they do have a lot of side effects. But they are shown to work in well-designed randomized controlled trials, proven efficacy. But over a third of patients can't tolerate even the lowest dose of amitriptyline, drowsiness, anticholinergic side effects, and so on. So these have resulted in their replacement by other agents as first-line drugs in many countries, including yours. So the newer agents I'm talking about now into this century are gabapentin, pregabalin, and so I'm going to talk about duloxetine as well. So gabapentin, of course, was the first of these, shown just at the end of the last century by Bokonja from Texas, a large randomized controlled trial that these were more effective than placebo in managing painful neuropathy. But 3 times a day dosage is a problem, and also a high dosage. The average dosage needed here is not 300. It's about 1.8 to 2 grams a day in 3 different doses. The daily pain scores and sleep disturbance were less on gabapentin. Its efficacy was equivalent to amitriptyline, but the side effects were less. And then, of course, we had pregabalin, and this is an alpha-2 delta subunit blocker here. And you see this happening here, and it reduces neurotransmitter here in the hyperexcited neuron in the synaptic cleft. Here's a summary by Roy Freeman, who was on our committee as a neurologist from Harvard for the position statements. Here's a pooled data analysis, and the dosage is between usually 150 and 600 milligrams daily in divided doses. America tend to use TID 3 times a day, but Europe, certainly, we only use twice a day. And there is, by the way, one coming out soon, which is going to be once daily, slow release. It may be available in India, I'm not sure. But I have learned over the years to start low and build up, and be very careful in patients with renal insufficiency. Start on a very low dose for them, perhaps 25 or 50 milligrams. But the average dose is around 150 or even up to 300 milligrams twice a day. The pain and sleep interference reductions positively correlated with doses, and the greatest effect is with 600 milligrams a day, but of course, side effects are more common with higher doses. Dizziness, somnolence, peripheral edema. But pregabalin treatment across the dosing range was associated with good improvement of neuropathic pain in all these studies that he reviewed. Now we have duloxetine, which is a dual inhibitor, 5-hydroxytryptamine and norepinephrine, noradrenaline, reuptake inhibitor. Its efficacy in diabetic neuropathy has been proven in 2 pivotal trials and more since. It's licensed across the world for diabetic neuropathy. This is also an antidepressant, whereas the gabapentinoids, particularly pregabalin, is anxiolytic. And this works here, as you see, a dual blockade here, transport of 5-hydroxytryptamine, reuptake, and norepinephrine or noradrenaline. So both duloxetine and pregabalin have level A evidence. That's randomized controlled trials and meta-analyses for neuropathic pain and diabetes. They're licensed across the world. They're both recommended as first-line therapies. I'm just giving you one example of the European Federation of Neuropathy Societies. They're both recommended as first-choice possibilities by the UK NICE, but the results of the combo trial, which is a combination study, were inconclusive. And this was published about 12 years ago, but it was sponsored by one of the manufacturers of one of these two drugs, I won't say anymore. And I think people are more interested in the more recent study, which is the Option Diabetic Neuropathy study by my friend and colleague in Sheffield, where I trained, and he followed me, Professor Solomon Tesfaye and colleagues, a multi-center study. This is the optimal pathway for treating neuropathic pain in diabetes. Basically, amitriptyline, duloxetine, and pregabalin were shown to be all equally efficacious. They looked at the combinations. The combinations led to a further drop in the pain score of about 1. Combination therapy well tolerated, and I was interested to hear that Torrent have now got a combination, which will be interesting to see. The study is on this. And the fewest monotherapy discontinuations when combined was the combination of actually pregabalin and amitriptyline, but the others worked as well, such as duloxetine and pregabalin. So this is the Option 2 study. It was published in 2022 in the Lancet. You can look at that. So this is an algorithm, if you wish. If this pain is due to diabetes or not, I can't read the top line here, so I can't see what it says. If you're not sure, refer to a neurology clinic. If you are sure that this is diabetic neuropathy, assess the comorbidities and potential for side effects. For example, patients with significant cardiovascular disease or older patients, you should not really use amitriptyline. Drug interactions, cost, etc. So the 3 first-line drugs, as I've said to you, are the drugs such as gabapentin and gabapentinoids, if you like, pregabalin, especially pregabalin now. The serotonin norepinephrine reuptake inhibitors, duloxetine, not venlafaxine, it's not used in Europe, and the secondary amine tricyclics, which is the antidepressants of which amitriptyline is best studied. If there is no clinically meaningful effect, then try and combine, perhaps switch to another agent or combine. And now I hear you've got a combined drug, which could be very useful. I think I'll come back to tramadol because the ADA is now very much against the use of opioids at all. So this is what's put in the most recent position statement on diabetic neuropathy. Now, opioid-related deaths, sadly, are very common in America. In 2019, I was actually planning the neuropathy section of the ADA program. That was a meeting just before pandemic in San Francisco. And I chose to put a symposium on the use of opioids in diabetic neuropathy. And we were given the first afternoon. You know, it starts on a Friday afternoon. I thought there'd be nobody there. 2 weeks before, the state of Oklahoma suddenly published all these lawsuits that were starting against companies manufacturing and really over-expressing the validity and usage of opioids, leading to numerous deaths. And the actual symposium was packed out in a small room on a Friday afternoon. So the ADA does no longer recommend the use of opioids at all in the management of diabetic neuropathy, not even tramadol. This was a study from your country, and it was published a few years ago, naltrexone, which is an opioid receptor antagonist compared to amitriptyline. This was shown to be useful in a small study in one center. But of course, this is interesting, but I don't know if there have been any larger studies since. Other potential studies, topical, and there is this capsaicin patch, if you like, 8% patch, and this was a large study of this in 2017. And my friend and colleague Reinhard Reinigen, who is a pain specialist from Germany, published this post-hoc analysis of 2 large follow-up studies to look at this patch application and showed there was good improvement, 28 to 30% improvement at 6 months, 47% at 1 year. So this is maybe a useful topical treatment in some patients. Most interestingly and recent is the development of high frequency spinal cord stimulation. And in this study from Erika Peterson, a neurosurgeon and colleagues from the United States, a multi-center study, Of course, this is invasive, but I'll show you on the next slide that basically there were only 2 minor infections on the skin requiring device explant in this study. And here is a study, it's easier to see it than this way. This is at 1 month, and this is those who are having randomized at kilohertz rather, spinal cord, high frequency color, spinal cord stimulation, plus standard of care. This is standard of care alone, medical therapy. And you can see the huge difference here in reduction in lower limb visual analog scale in centimeters, 10 being the worst. And you see this drop here from around 7.5 to roughly 2 or below 2 in the group who had spinal cord stimulation. Again, no side effects. So this is interesting. It's been increasingly used in the United States. So here's the algorithm rewritten since the ADA, but the ADA would agree with this. That's the same, that's the same, that's the same. Pain control, still inadequate. Combination, then possibly opioid agonist, possibly, probably not, but capsaicin passed, but now spinal cord stimulation is being widely used in the USA in severe neuropathic pain in diabetes that doesn't respond to anything I've talked about already. This is an area to watch. For the last 2 or 3 minutes, I apologize for the late start. Last 2 or 3 minutes, I'm just going to say a couple of things about small fiber autonomic neuropathy you might not know. One complication is gustatory sweating, which is profuse head and neck swelling. And it never goes sweating, not swelling. It doesn't go any lower than here. It's usually in the front of the face or the hair. And it's so severe, eating foods, that some patients have to wear a towel around their necks. It drips off the face. This is profuse facial sweating whilst eating. The most powerful stimulus is cheese. Now, I could say that I know that the Madras curry is excellent, but that can stimulate it too. And I'm sure that spicy food does. Atropine and oral cholinergics have been shown to eliminate symptoms, but the side effects were worse than the symptoms. And Peter Watkins, who described this from King's College in London, said he thought the symptoms were due to abnormal nerve regeneration in autonomic neuropathy. In other words, what's happening? The nerves are dying, and diabetic neuropathy is an active process of regeneration. And small fibers destined for the salivary glands were going to the sweat glands. Hence, this profuse sweating when you eat. Now, we were able to show that he was wrong on that. And this was a study we published, and Jonathan Shaw, some of you may know him, he was my research fellow in Manchester in the late 1990s. He's now a professor of medicine, especially epidemiology, with Paul Zimmet in Melbourne. This is a study we published of 196 patients with gustatory sweating. 69% of those with nephropathy reported, diabetic nephropathy reported gustatory sweating. There's only 39% of those with neuropathy, so nephropathy. I've run a big diabetes renal clinic for 35 years, and I see so many patients on dialysis with end-stage renal disease without starting dialysis. They've got this profuse sweating. And what we showed was that about 9 out of 10, the day after renal transplant, this disappears. So it can't be due to aberrant nerve regrowth. This must be a metabolic phenomenon. We were also able to describe a very efficacious and side effect-free treatment. And that's a topical drug, glycopyrrolate, antimuscarinic anticholinergic drug, a topical glycopyrrolate, pyrrolate TG, I'm going to call it from now on. We did a randomized controlled trial crossover where we gave a set meal and measured sweating in a certain area of the face. A crossover design with a placebo paste or cream. They put this on once a day, it lasts 24 hours, and compared to placebo, topical glycopyrrolate reduced sweat response to challenge by 82%. And nearly 100% of those with severe episodes of gustatory sweating was removed or reduced with this topical treatment that has no side effects. So this is a treatment we use for this very uncomfortable and really socially depriving, because patients don't like to go out for a meal with friends because they have to put a towel around their neck and sweat profusely, even if they're just having a sort of mundane English meal like fish and chips. Lastly, what about, not dissociated from this, diabetic autonomic diarrhea? Again, the history matters so much. We see this a lot with people with gustatory sweating and people with diabetic nephropathy, end stage, and extensive neuropathy, especially autonomic neuropathy. This is intermittent bouts of explosive diarrhea. It's usually preceded by loud borborygmi, and that's Latin. I don't know if you still use that in medical school. Borborygmi is the bowel sounds you can hear. These patients give a classic history. They suddenly get this noise, like a gurgling sensation and audible stimulus. They can hear this. And then in a few minutes or hours later, they suddenly have to go to the toilet and have profuse diarrhea, often associated with fecal incompetence, because autonomic neuropathy can affect, of course, the sphincters as well. It's invariably worse at night. It lasts a few days, then it goes away, and it can be interspersed with periods of constipation. This is caused because of sludging of food, because of reduced peristalsis as a consequence of autonomic neuropathy. Now, if I send them to a gastroenterologist, they spend 6 months doing lots of tests, breath tests and all sorts of scanning of motility tests. When I say to them, look, I take a history, I can diagnose this by the history and the examination, because I've also got a dense neuropathy, other signs of autonomic neuropathy, often gustatory sweating. I put them onto doxycycline, low dose, 100 milligrams daily, taken in the late afternoon, and it usually wipes it out, and not for long, because then you reduce the bacterial count and it returns to normal. If you carry it for too long, then the patient will become constipated. So this is just a sort of a tip for gustatory sweating and autonomic dysfunction of the bowel. So with those words, I will conclude with this slide by Henri de Monville in 1320. And he wrote these words: anyone who believes that anything can be suited to everyone is a great fool, because medicine is practiced not on mankind, but on every individual patient. So the take-home message is, in neuropathy, in autonomic neuropathy, take a careful history, listen to what the patient says and hear, examine them, look and see. Medical students often look, but they don't see. Look and see the abnormality and see if you can approach it. If you need any tests to confirm it further, obviously examine the patient for neuropathy and so on. With those words, I'll say, Dhanyavad. Thank you very much.
Thank you very much, sir, for those excellent insights on the topic. We have few questions from the audience. Since you are leaving early. Yes, sir.
So we can have a question now, as Andrew had to leave.
Yes, exactly.
Yes. So is vitamin B12 supplementation is important in patient with diabetic peripheral neuropathy? Those who are long-term metformin.
Of course, B12 deficiency can cause neuropathy, but it's very rare in well-nourished societies. You may see it in some very poor sub-Saharan African countries, but it's rarely a problem in diabetes. Perhaps if you're on metformin, you need to perhaps check the levels, but I think that it's not used as a therapy for diabetic neuropathy in the UK, unless there is an abnormality, and it's most common in patients who are on metformin.
And one common question is asked that, tricyclic antidepressant in India is very commonly used. So the people who have sleep disturbance or depression, do you suggest that instead of using only pregabalin, it's better to use tricyclic antidepressant? And then someone asked that yes, compared to that, is the duloxetine is better?
Yeah, but what Loretta's studies have shown is that people with diabetic neuropathy tend to be, with severe pain, tend to be anxious. So pregabalin may be the worst one. If the patient has depression as well, then duloxetine may be the drug of choice. It has equal efficacy, but fewer side effects than amitriptyline. Now, amitriptyline, we still use it, but selectively. As I said, not in older people, certainly not in people with any cardiovascular disease because of the risk of arrhythmias and so on. So it is a useful drug in the right patient, if they can tolerate it.
Is it, I mean, for all people with diabetic peripheral neuropathy, will there be possibility of diabetic autonomic neuropathy or gastroparesis? And should we investigate for it for each and every patient?
Yeah, I think that gastroparesis is a very difficult one because there are so many causes. Obviously, the GLP-1s to slow gastric emptying, and the number of people on those these days are going up and up. So it's a very difficult one, and severe gastroparesis is pretty rare, thank goodness, because there are no good treatments for it. And the investigations can be very complex, such as a labeled meal to look at gastric emptying and so on. I think the history again will tell you for severe gastroparesis, especially the vomiting some days later of food eaten a few days ago, and this kind of sign or symptom.
So with those who have severe neuropathy, the more chances of gastroparesis. So can it become a relative contraindication to use GLP-1, or I mean,
I think you
or
should
they
be
will
very
have more
careful.
symptoms?
Someone with long-standing diabetes with a dense neuropathy, I would take a history to make sure that there isn't subclinical. If you take the history, you may find out more than spontaneous volunteering of symptoms. You may find out more by doing a careful history before you start the drug. That's what I would do.
Suppose someone have diabetic autonomic neuropathy, and because of that, there is a pedal edema and renal dysfunction or hepatic function and cardiac function absolutely fine. So how to manage it? It is because of only diabetic autonomic neuropathy, no drug induced, not pregabalin, nor glitazone, not fluid overload. So what could be the management for those?
There have been many studies looking at this, but there's really no drug on the market that helps neuropathic edema. I think it's pretty rare. It may be related to changes in insulin. You can get insulin edema, of course, suddenly increasing the dose. And people with eating disorders know that, because the patients are brighter than the doctors. They know if you suddenly increase the insulin, you get a lot of fluid retention. You go to the psychiatrist and say, well done, you put on weight. And you go down to taking hardly any insulin and you lose it all again. So we know that insulin is a cause of that. So take a careful history. The commonest causes of pedal edema are drugs and misuse of drugs. I say apart from obviously chronic renal failure, cardiovascular disease, and so on.
Suppose someone who is painful neuropathy, and now because of the drugs therapy, the pain part is improved, but still the chances of sensory polyneuropathy will not be improved or it will not be recovered. So what precaution they should continue to take throughout the lifetime, just other than preventing the diabetic foot complication?
The natural history of diabetic neuropathy isn't that well known, but most people believe that it's a sort of fluctuation. But most people believe that painful symptoms don't last forever. And danger is keeping people on drugs forever. So what I do after the patient's stable for a few months, and they say they're on pregabalin, 150 milligrams twice daily, and I say, well, what we'll do, let's reduce to 75 and 150. And then if the pain doesn't come back, reduce to 75 twice a day. A gradual reduction. If the pain comes back at one level, then you step up to the one before. You may be able to reduce the dose and eventually stop it. And I don't think you should believe that any of these therapies is a drug for life. That's
So
wrong.
it can be stopped also in between. That's a good news.
Yeah, and it may not come, the pain may not come back. That's what I'm saying. Yeah.
Is there any reason differences? I mean, this ADA had come out with a peripheral neuropathy guideline, but do you think those in Asians or Africans, they will have, they should have the different guideline for peripheral neuropathy management?
Who should have a different
guidelines, like
different
from
geographies or
Asians,
ethnic groups,
geography
do they
can
need
have.
different guidelines?
I think that the symptoms and signs of neuropathies are pretty similar across the world. There's no evidence that that's not the case. I think that it's difficult to answer that one. I think there aren't any good studies across different races. But I see it, and we have a huge number of races. If I combine Miami and I combine that with what I see in Manchester, where of course we have a large Indian subcontinent population, we don't see less. We see perhaps less foot problems we used to see in patients from Indian subcontinent because they have hypermobility of joints. So they start at an advantage. So if you get non-enzymatic glycation, you don't get the high foot pressures that people, Caucasoid patients get, which is very useful. And also Muslims, of course, remove shoes and socks and look at the feet and pray X times a day. So this is very helpful. But apart from that, diabetic neuropathy affects everybody, basically. Doesn't have to, with good prevention, good control from diagnosis, etc. There will be, I mean, there's no doubt that I know some patients, I've got some patients with diabetes type 1 for 50, 60 years, with average or poor control and haven't got a single complication. And there's others who have been excellent control, and they're plagued with all the microvascular complications. So the genetic influence is very high.
Thank you, Andrew. It was great. And once again, thank you very much for sparing your very valuable time. As today is 13th August and 15th August are Independence Day, today we capped this program specifically just to say that we are now going to have a freedom from painful neuropathy. We are going to have a combination of drug which will include duloxetine, pregabalin, and methylcobalamin, which is be available soon in our country. And with this, now I introduce and invite Dr. Shashank Joshi for the latest management guideline. Dr. Shashank is an eminent.
Thank you.
Oh,
Thank
yes,
you,
yes, Andrew, you can give. Thank you.
And
Thank
thanks
you.
to Torrent Pharmacy, and it's been a pleasure.
Thank you. Thank you.
all.
So requesting Shashank to share the slide. Everyone knows him. He's an eminent endocrinologist, diabetologist, who is going to talk on management of diabetic neuropathy with combined to combat pain in Indian context and data. Dr. Shashank is past chair of IDF Southeast Asia. He is past president of API Endocrine Society as well as RSSDI. So now I request Dr. Shashank for his talk. Thank you, Andrew, once again. Thank you.
So after this wonderful talk of Andrew, I don't know whether I should speak at all. Having said that, because this is a sponsored symposium, you know, I will give some of my pearls of wisdom, about management of diabetic neuropathy. So thank you, Bansi, for organizing this. And this is a Torrent talk. So we all know, and Andrew said it very clearly, that when we look at diabetic neuropathy, it's basically caused because of energy overload due to excess glucose and lipids. So fundamentally, there is a mitochondrial bioenergetic failure with mitochondrial depolarization at a cellular level. So there's a loss of adenosine triphosphatase as an energy source. And therefore, you get a lot of reactive oxygen species. And that process leads to impaired mitochondrial trafficking from the cell body in the length of axons, endoplasmic reticulum stress, apoptosis of neurons, and axonal failure. So that's what is happening in a diabetic neuropathy. So, just like we have beta cell stress, we have a term called Schwann cell stress. So when there is excess glucose and lipids, fundamentally there is mitochondrial dysfunction, and there is a lot of NADP oxidase and inflammatory signals. And on the Schwann cells, there is neuronal damage, which decreases the nerve conduction velocity, as well as microvascular damage on the Schwann cell, which causes decrease in the nerve blood flow. So this is the typical Schwann cell stress due to which neuropathy occurs. Now, Andrew showed this very beautiful slide where you can have metabolically healthy individuals where mitochondria produce in the neuronal cell traffic down the neurons and axons and provide energy for normal axonal function. But before people develop prediabetes, they start getting neuropathy. They start getting tingling numbness. They get a chain of injurious events leading to mitochondrial dysfunction, ATPase loss, distal to proximal degeneration of energy stored axons. So the time is crucial. Early symptoms of diabetic peripheral neuropathy occur in toes and fingertips, expanding over time over stocking and glove pattern. Sensations of stimuli like vibration, pinprick, temperature, monofilament histamine all get diminished over the same pattern. And Andrew illustrated it very well. So Andrew told us about this, that there is a small fiber and a large fiber neuropathy. The early injury of loss of small fibers is susceptible to energy flux, which often occurs with people with prediabetes and diabetes, resulting in burning of their feet, burning of their hand, and symptomatic pain. As the disease progresses, large nerve fibers are also become injured due to lack of energy sources and sense of loss of position sense in their feet. And fundamentally, then you get a classical diabetic neuropathy. So typically, what are the options? And Andrew did allude to them. Opioid is not an option. So we can start with non-pharmacological options of exercise, reduce sedentary behavior, dietary modification, energy or nerve stimulation like high frequency spinal cord stimulation, which is very beautifully illustrated, excluding other causes of neuropathy, and good glycemic control. Topical capsaicin 8% patch can be used. Combination therapy, which is what I'm going to talk on, we can use that. And of course, classical pharmacological therapies like anticonvulsants like pregabalin or gabapentin, SSNRIs like duloxetine or tricyclic antidepressants. So clearly, glucose control, blood pressure control, lipid control is key. Symptomatic treatment can be the duloxetine or pregabalin, as Andrew said, and second line is tricyclic antidepressants. And then pathogenic treatment, some people can use specialized agents. And these, recommended treatment approaches for painful neuropathy have been already highlighted. Andrew is a part of this guideline where the 2025 neuropathy treatment guidelines show optimized glucose control, optimize weight and blood pressure and lipid management, and reduce or slow or retard the progression of diabetic neuropathy. And then treat pain with symptoms and autonomic neuropathy. And clearly in the ADA recommendation, the level is A for gabapentinoids, serotonin norepinephrine reuptake inhibitors, tricyclic antidepressants, and sodium channel blockers as an initial neuropathic pain treatments. Opioids, including tramadol, tapentadol, should not be used for neuropathic pain in diabetes, given the potential for events. So two things. One is the classic agents and a strict no-no for opioids. ACE came out with its own algorithm. And in the ACE algorithm, the first thing they say is primum non nocere, which means in Latin, first of all, do no harm. And in that, they very clearly said, is the pain due to diabetic peripheral neuropathy? If the answer is no or not sure, follow and get an expert opinion. If it is due to diabetic peripheral neuropathy and the answer is yes, assess comorbidities, look at the cost, drug-to-drug interactions, and potential adverse events. And then you have 5 pathways. Exercise is the most crucial pathway, but the patch of capsaicin, tricyclic antidepressants like amitriptyline or nortriptyline, SNRIs like duloxetine or venlafaxine, pregabalin or gabapentin. If the symptoms persist, again, avoid opioids, switch from one agent or combine the agents. And if there's still persistent pain, then if the pain is not tolerated, refer to a painkiller. So if you look at different guidelines, the NICE, the Canadian, the EFNS, the new SPG, the first line, second line, and third line are almost similar. And you can see that in some of the guidelines, botulism toxin or tramadols also and cannabinoids find a space. So Andrew again alluded to this, that there is a treatment targeted to pain and comorbidity. If there's a proximal neuropathy, for example, IVIG, steroids can be given. If there is a diffuse neuropathy, gabapentin, pregabalin, exuloidate, clonidine can be given. And if there is a focal neuropathy or a mononeuropathy, then you can do splintin, lidocaine, or surgical entrapment like carpenter. This slide he alluded to very well. And we know that what's available in India. So in India, very clearly we have pregabalin, initiate with 50 milligram at bedtime, increase to 75 milligram after 48 hours. Okay, then clearly, if there is less than 50% pain relief, okay, increase their dose by 75 milligram per day every 4 to 5 days. And the maximal tolerated dose could be 450 milligram per day in 2 divided doses. But the adverse events are dizziness, vertigo, sedation, dryness of mouth, asthenia, and peripheral edema. There are no significant drug interactions. You need down regulation of dose in renal insufficiency. Sleep and anxiety comes down with pregabalin. Gabapentin I don't like. Of course, it's still used. Everything else is similar to pregabalin. Duloxetine has been a treatment of choice. It has additional benefit of reducing anxiety and depression. In fact, 20 milligram once daily at bedtime is a standard of care. You can titrate up to 60 milligram 2 divided doses. Higher doses in individual cases can have a risk-benefit ratio. You can get nausea with or without vomiting, constipation, decrease in appetite and dry mouth. And you don't use it in severe kidney or renal dysfunction, alcohol abuse, use with tramadols. And, if there is mild to moderate hepatic or liver impairment or kidney impairment, then start with the lowest dose. If there's mania, seizure, acute narrow angle glaucoma, don't use it. And remember, it can increase suicidal risk. Venlafaxine, again, similar data. And then, of course, the amitriptyline. Start with 10 milligram. But the problem is anticholinergic side effects and dizziness. and
These
of course
points
it
are
elevates
really
depression.
Correct.
And clearly
So,
not
very well
reptilian.
said that you need to
Also-
look for.
And I want to add
Yeah.
one thing is Balsi sir
Hello?
was telling about CGM. So
Hello?
this timing.
Nankishore, can you just mute others?
Hello? Hello, can you please mute? You all are cross talking. Okay, and then of course we have tramadol. So clearly, if you see the treatment challenges in diabetic neuropathic pain, first is involvement of more than one mechanism in etiology of neuropathic pain. Only half the patients achieve meaningful pain relief with available therapies, inadequacies with monotherapy, and then of course we have to look at depression and sleep disturbances, because one of the most common cause of neuropathic pain and lack of relief of pain is associated depression and sleep. So for India, the approach is start oral therapy, either with a pregabalin or a gabapentinoid, TCA or SNRIs. Wait for 2 to 4 weeks. If the response is adequate, continue the treatment. If there is no response or not tolerated, switch treatment. And then go to a combination. And then add additional treatments of tramadol or psychobehavioral therapies. And if there is no effect, we can see. How do you choose drugs? Now, pain severity will determine early combination. If you want fast pain relief, quality of life, sedative drugs for sleep quality. People who sleep less, improve that. Can you please shut up? And otherwise go to the other room, please, because I am live with 2,000 people. Inadequate pain control with and side effect profile with lower side effect profile, comorbidities like renal, hepatic, cardiac, psychiatric, and affordability and availability. Now, one important thing which all of us should know, and this is a disclaimer, that whenever you use amitriptyline-like drugs, you could get a cholinergic toxidrome. And we all know the muscarinic and nicotinic symptoms like salivation, lacrimation, urination, defecation, GI cramps, and emesis, which is the sludge. That's the mnemonic people use, or the nicotinic symptoms like muscle cramps, tachycardia, weakness, twitching, and fasciculation. And we should be mindful that some of the combinations can lead to a cholinergic toxidrome. So what are the triple combinations in India? Because Torrent has some of them. One is pregabalin, methylcobalamin, and duloxetine. There was a question on that. Then there is a combination of pregabalin, methylcobalamin, and nortriptyline. And then gabapentin, methylcobalamin, and nortriptyline. So let us look at the advantages of triple combination. Number one, it targets multiple pain pathways, peripheral, central, and nutritional. Number two, it addresses treatment gaps in unresponsive to double therapies. And number three, it enhances compliance through a fixed dose combination, which is once a day pill. And the pill burden is reduced. And if there's a coexistent B12 deficiency, which is a substantial contributor to peripheral neuropathy, particularly in the vegetarian vegan population, that is also sorted out. So let us look at data. And I think this is the most time-tested combination, pregabalin plus methylcobalamin plus duloxetine. And that's something which I use. Pregabalin will block the alpha-2 delta subunit of the voltage-dependent calcium channels. The duloxetine will block the reuptake of serotonin norepinephrine pathway in the distal inhibitory pathway. And the B12 will basically is a myelin sheath promoter for regeneration and improved transmission. So clearly, if you see the grade recommendations from the revised special interest group of neuropathic pain, duloxetine and pregabalin have high quality of evidence. The efficacy is moderate. The tolerability is moderate for duloxetine, moderate to high for pregabalin. Strength of recommendation is strong for both. And the neuropathic pain conditions are universal for both. So this is a synergy which is possible with moderate efficacy, moderate safety, high quality of evidence, strong recommendation, and for all neuropathic conditions. Now, when it comes to the duloxetine versus nortriptyline, affinity towards adrenergic cardiac receptors is not there for duloxetine, but is there for nortriptyline. On the glucose, because we are leading with diabetics, duloxetine does not disrupt the glucose homeostasis or insulin sensitivity, while there is a hyperglycemic effect with nortriptyline. With cognition, there is no effect with duloxetine, but remember that you can get impaired thinking or reasoning with nortriptyline. And duloxetine is comparatively weight neutral, while nortriptyline promotes weight gain. And the cholinergic toxidrome, which I said, is less than 5% with duloxetine. It's more than 10% with nortriptyline. What about methylcobalamin? But it improves the nerve conduction velocity. helps regeneration, myelination, restoration, improving symptoms. Methicobal is well tolerated. It improves adherence, compliance, pain, sleep disturbance, nerve function, and basically is an adjuvant. And it has some neurotropic effect on the equilibrium. So there is some clinical evidence, and this is a study data, which is a multi-center trial, randomized phase 3 of the fixed dose combination of pregabalin, methicobal, and duloxetine, delayed release capsules versus FDC of pregabalin, methicobal, and nortriptyline in diabetic peripheral neuropathy with coexisting vitamin B12 deficiency. This was done over 12 weeks with 200 patients and with 20 milligram and 30 milligram duloxetine and nortriptyline. 75 milligram was the pregabalin dose in the arm A, arm B, and reference arm C. And you can clearly see here on the visual analog scale, in arm A, arm B, and arm C, you could see that there is a clear-cut differential which is seen. And the mean change of baseline of the VAS score is statistically significant with a significant p-value. The secondary efficacy parameter is the LANS score, which is the Leeds Assessment Neuropathic Symptom Signs Pain Scale. And you could see that there is a statistical difference which is seen in arm B, arm A, and arm C, respectively, from the baseline. So clearly you can see that as a numerically greater reduction was seen in arm A and B versus arm C, and clear-cut improvement was seen. Adverse events were seen in all the arms, but the proportionate adverse events were different, and there was no discontinuation due to the same. So clearly, the pregabalin, methicobal, and duloxetine 20 and 30 milligram showed a statistically significant efficacy compared to pregabalin, methicobal, and nortriptyline without any safety concerns. So my last slide is that we have a lot of treatment options available, and fixed dose combinations in this space are there as a second, third, or a fourth step. And we need to look at it, but you need to use lower doses. Clearly, the duloxetine-based triple combination has a significant advantage over nortriptyline because we know that there is a cholinergic crisis. In fact, if you go online yesterday, we have written an article of a cholinergic crisis in the Diabetes Care, which has just got online. So I think I'll stop here. And I'm sure that Andrew has answered quite a few questions. It is quite late in the course of the day, but I'll be happy to answer if there are any questions related to my topic. Thank you.
Shashank, one that, India is a country where fixed dose combination is very popular. One of the reason is we want to use less number of pills, and that may be one of the biggest advantage. It's not that duloxetine is new drug, but this combination, where you will fit. I mean, normally people start only with pregabalin or only with methylcobalamin, or B12 is already on there. Then we give this pregabalin, methylcobalamin, and then we add duloxetine. So do you think this will be an advantage that every patient now we can start with straight with triple drug combination, or still we have to continue with pregabalin, methylcobalamin, and then we have to add? That's number one. And second is pregabalin is originally when the molecule came, it was for twice a day. Pregabalin, 75 milligram, was the Lyrica was the introduced, and then we found that actually it causes a lot of giddiness and all those issues. So we stopped using it morning time and only started giving evening time. So do you think that it will work only if we give once in a day along with duloxetine? Will it be okay, or should we still think of giving it twice a day? What is your take home for that?
Mansi, it's very clear that if you want to do flexibility and titration, you can't use a combination, which is fixed dose. So that is completely ruled out. But you see, when I'm sitting in a tertiary care setup, so I see burnt out cases. So people are already prescribed a pregabalin or a duloxetine, and then I have to top it up. So clearly the first line agent is a single agent, but it also, as I said, in assessment of a person, sometimes our first encounter is our last encounter. So if you want, there is moderate to severe neuropathy with pain predominant and disabling bilateral symmetrical neuropathy, using a dual combination of a low dose duloxetine with pregabalin is reasonable, and it gives you excellent relief. The only challenge is sometimes with tolerance, because both these drugs can be reasonably heavy. But most of our patients are either on a duloxetine separately or a pregabalin separately, and then it is easier to use. If you see all the protocols are very clear that start with a single drug and then go to a combination. So there is no question asked on that. The B12 component comes in the picture mainly because we have a high prevalence of B12 deficiency in our population, and B12 matters in the nerve health. So that is something which we recognize. But the biggest problem which I see is B12 is a water soluble vitamin, not a fat soluble vitamin. So unlike D, which causes toxicity, the B12, if it is in excess, and people often estimate as B12s, they get paranoid and they feel that it will damage their brain. All nothing like that happens. It's a water soluble vitamin, so you'll enrich the urine of your city, and more mosquitoes and more dengue and leptospira will spread. But something which we recognize very clearly. So that's something which we all know.
One more, somebody had asked that, have you ever tried palmitorlithinomide to treat peripheral neuropathy?
Yes, I have tried. In
Uh,
brittle cases, I have tried it, and it has some impact. It's a good adjuvant. We see often brittle cases, so we'll end up with multiple medications, and we definitely try some of these pharmacoadjuvants. But the evidence-based, it's not an evidence-based agent with high science. Duloxetine and pregabalin is evidence-based science.
What about the role of alpha lipoic or gamma linonic, or these were the agents which we used to use, and with very high dose they are effective, but normally
So most
used
of
by
the
some
data came
therapeutic.
from Germany, from Ziegler's data, and they were all given IV. The doses are quite pharmacological, and most of us use subtherapeutic doses
Yes,
for
that
these
is
agents. But more or less, with the advent of these dual combinations, I think the use of these agents has gone down and dwindled.
Any other question?
That's it, sir.
Okay, great. So, Shashank, should we close the session?
Sure, thank you.
Yes. So
Happy
once
Independence
again,
Day to
thank
everybody,
you. Yes.
and wish you all freedom from nerve pain. And I hope that this education allows you to treat your people living with diabetes and crippling nerve conditions better. And thank you,
Great.
Torrent, for organizing this symposium, and thank you, Bansi, for steering this show.
Thank you. Sanjay, if you want last minute, any vote of thanks or anything, please, Sanjay, bhai, Amish, anyone, and then we close the session.
Yes, sir. Good evening to you, and good evening to Professor Shashank Joshi. Good evening, delegates. We have over 2,700 delegates attending this
That's
session.
great, really. Congratulations.
And it was really remarkable listening to Professor Andrew Bolton, to Professor Shashank Joshi, discerning the nuances of peripheral diabetic neuropathy. And it was a great pleasure for all of us to have you as esteemed speakers during this session. I would like to thank Dr. Bansi Sabu for providing this platform of Diabetes India to launch our product, the triple combination, and also address the delegates here. So on behalf of Diabetes India, I would like to thank all the delegates here for taking time out and making it convenient to attend this session. Thank you very much, sir. Thank you, Professor Shashank Joshi. Thank you, Dr. Bansi Sabu. Thanks
Thank
a
you.
lot.
Thank you, Sanjay. Thank you, Torrent. And thank you, Amish bhai, for organizing great meeting. Dr. Lokesh for providing all medical support. Thanks, Shashank. And thank you, Sanjay and Andrew Bolton. Everyone. Thank you. Good night. Thanks, everyone who joined today.
Thank you, sir. Thank you so much.
Thank you.